Good afternoon, everybody. I'm Cesar Sutuyo. I'm the Vice Chair and Chief of Child and Adolescent Psychiatry at UT Health Houston, and it's a pleasure for me to be here. Thank you very much for attending this session, and thanks for inviting me. I have to say, Jackie, that the first time that you sent me the message that we're going to have a meeting in Austin, and if you can do it, I kind of look at my calendar and I say, yes, I can do it, that's fine. I clear my day. And then I then look at the conference that we are doing, because I was thinking we were going to a medical conference, all right? And then I found out that I was going to a digital learning conference, and then I start struggling and thinking, what am I going to say? How can I say something interesting to these people that are experts in teaching and education? So what I'm going to try to do in the next 5 to 7 minutes is to give you a clinical example, because I'm a clinician. I evaluate and I see children with attention deficit hyperactivity in the clinic every day, and give you an example of how there are different parts in attention and how we can measure that and how we use that in the clinic, but also in the general population, to kind of individualize the treatment or the care that we give to every child, and look at the needs at every single moment through their life as a student. Because I see kids from age 3 till they become 18. All right. So these are my disclosures, and this is relevant because I'm in the International Advisory Board for Neurotech Solutions, and I'm also finding myself more and more giving advice to tech companies now that are developing tech tools, also to do psychotherapy through apps and things like that. There's a lot of movement in the area, so this is a booming area right now. And I thank everybody for their support and interest in what I do. Again, thank you everybody for having me here among these distinguished speakers. And this is my agenda. I'm going to talk a little bit about what we call ADHD, because people tend to think that we, the psychiatrists, call everybody ADHD, and that 90% of the kids in America are taking Ritalin. And I wanted you to know that that's not true. All right, we actually have an interview and have a clinical evaluation and go through a formal process to make a diagnosis. Then we touch into the biology of ADHD, or it really is the biology of attention, because there's parts of the brain that are working when you're paying attention and when you're thinking about other things that are as different as the foot and the eye. And there's organs in the brain that are doing different things. And people sometimes they don't realize that. And then how we clinically measure attention, in this case with this particular tool with Moxo, but how then we can inform the treatment or inform even the schools about some accommodations that they could make. Of course, when teachers ask me what accommodations I need to do for this kid, my answer is always the same. I say, I'm just a doctor. I don't know what, it's your job to do the accommodations, because you are the teacher. You know how to teach. I just know that this kid has difficulties in these areas, and then you have to figure out how to do it, because I'm not an expertise, but we can go hand in hand and then get there together. All right. So let's see. We go to the next one. Okay. So first thing that I wanted to say is that the symptoms of ADHD appear from early age. So these are kids that from early age you can see the symptoms, and that we're always comparing them with the expectation for normal development. So and I think, as opposed to parents, teachers are in a very, very good position to assess the attention and the hyperactivity of the kid, because they are exposed to to a lot of kids through their career. So they kind of say, oh, this is a little bit hyper, but this kid is more or less within normal limits. And we do find this when we do rating scales, that the teachers tend to score lower and the parents tend to score higher, because if they only have 1 or 2 kids, then they may think that this is the end of the world for them. That it also has to appear in several settings. So the symptoms are supposed to happen in different settings. If it's something only happening at school or at home, that's probably not ADHD. And then the most important part here, the fourth line here, is that it has to cause impairment. So we are always looking for impairment, and just the presence of symptoms is not enough to make a diagnosis. And then it's not due to other causes. For example, a kid who's taking asthma medication can be very jittery and hyper, and that doesn't mean that they have ADHD. Same with epilepsy medication, they can be very sleepy. Or if the kid is having depression, for example, they may be not interested, and that doesn't mean that they have ADHD. So there's three kind of symptoms, and they vary and they change over time. The first one is impulsivity, and if you look here at the bottom, preschool, school age, and adolescence. So the symptoms starts high and then decrease over time, and that's why in the past people would say that ADHD is a disorder that only appears in children, because impulsivity and, as you'll see, hyperactivity disappears in adolescence or tend to go down. This is the pattern for hyperactivity. It's very high in early age and school age, and then it goes down in adolescence. And then inattention is the one that is going to increase, in part because the expectation in preschoolers is quite low. So the normal developmental expectation for that kid is not to pay attention for half an hour in a class. They're going to be moving around. They're going to go from one thing to another. So it's very difficult to differentiate from normal development. And then the other thing that happens is that what we call in psychiatric comorbidity. So other disorders that appear at the same time tend to increase, especially if we don't do anything early on. So these are kids that are going to have more anxiety, more depression, more negative behaviors, more oppositional defiant disorders. All right. So as you see, depending on the age, when you see the kid, if you see them in early age, you're going to see just hyperactivity and impulsivity. If you see them in school age, like 6, 7, 8 years old, you're going to see the three classic cluster of symptoms: hyperactivity, impulsivity, and inattention. And later in adolescence, you're going to see more inattention, and more impulsivity. Okay? All right. And then at the end, in early adulthood, you see also the comorbidity, and sometimes it's totally missed, and then people blame it on the comorbidity. I have young adults who have been diagnosed with anxiety, and then when you dig a little bit, they have ADHD underneath. All right. So when you look at the brain networks, so that would be the symptoms of ADHD. Now we're looking at the brain networks that are relevant to attention. There's these 5 networks that are involved in attention, and I'm just going to talk about the last 2 ones, okay? But I just wanted you to know that there's others. And the first 2 ones, dorsal attention and ventral attention, are relevant to the task that you're doing. So they're the task positive networks. And the second one, ventral attention, is also involving auto instruction. So that come on, do it, come on, you can do it, let's finish it. Okay, no, don't get up yet. You have to finish your tax return first, and then you can go to run or whatever you're doing, okay? Then the third one is the default mode network, and that's responsible for mind wandering, for thinking about something when you're not doing anything, and that is important. We'll talk about that at the end. And then the ones that I want to focus is the salience and limbic, which is responsible for reward processing and emotion, and that is what is called the hot executive function. So that is when you make a decision, I want to buy that is a really nice car, I really like it, boom, you buy it. Okay, you make an emotional decision without thinking properly through all the steps. The last one is the frontoparietal network, and that is the anterior-posterior network that is going to make you go through a decision in a very rational way. So you kind of think of all the steps and possibilities, and then you make a decision. That's also called the executive function network. Okay. All right. And this is very well illustrated in this very nice book, which is called Thinking Fast and Slow, because you do need those 2 kind of thinking. And you can see what happens when someone is absolutely rational with everything. They don't have any emotion. They make the right decisions all the time, and that's the wrong thing to do, because sometimes you have to take chances, and sometimes you have to do something with a little bit of emotion. And there's sometimes in in human development, you're walking down the forest and you see something like moving there. You don't have time to decide whether it's a snake or an alligator. You have to jump and you have to run away, and then you save your life. Otherwise, your genes are not going to go to the next generation. So that's kind of ingrained in our system in order to survive. So the hot executive function, it can make you make bad decisions, but also good decisions very, very fast. So that is important. All right, and this is where they live in the brain. So the in blue is the frontoparietal control, and it has the different parts. And then in red is the salience and limbic. Okay, and I'll go through those in little by little. So first is the dorsolateral prefrontal cortex, and just forget about the names. Don't worry about the names. It's the one in the front, this one here. All right, and that's what is giving you selective attention. That's what is focusing on the main task that you're doing, and it's also allowing you to switch tasks, and it's also allowing you to think into the future, like position your decision into the future and see what happens. Sometimes you don't have to do something, and I tell my patients sometimes, that tree was already too high to climb, and you knew you didn't have to climb and jump off the tree to really know that was a really bad idea. Yeah. And then he said, I realized it was a bad idea when I was halfway through, and then I said, oh no, I'm going to break my legs. Yes, you did. All right, and those are true stories. So, and then processing speed, working memory, and motor planning are also living in the dorsolateral prefrontal cortex. Motor planning is like when you're in a nice dinner with very tall glasses and you want to grab the glass of wine, you have to make sure that you don't touch the other glasses, and then you make a big mess. Kids with ADHD or kids who may have problems in this part of the brain, they are unable to plan the movement in their head before they do it, and just go ahead and do it, and then everything is a mess. All right, so sometimes that's why teachers say and parents say that this kid is behaving like a younger kid, because they actually haven't developed that part of the brain at the level that they should. All right, the other part of the brain is the inferior frontal cortex, and that's involved in inhibition. So don't do this, wait a little bit, and then do it later. Timing, so things have to have a rhythm, and sometimes you have to wait, sometimes you have to go faster. And then selective attention, so focus on a particular thing, ignoring other things. All right, and then in the parietal cortex, so that's the back of the brain, that pays attention to space and time, and then that gives you cognitive flexibility. When I talk to parents, I tell them that the back of the brain is like the co-pilot in a car, who's going to tell the pilot, be careful, there's a turn to the right over there. So they're presenting stimuli to the front of the brain, and then the front of the brain is the one that is making the decisions, okay? When you look at and then there's a cognitive component on this part of the brain, also on the cingulate cortex, and that's more internal, okay? Then when you look at the salience and limbic circuits, then you have this anterior part of the cingulate cortex, that is the affective component, all right? And then you have the nucleus accumbens, which is right there in the middle of the brain. That's the part of the brain that makes you want to do things that you like doing. So when you eat a chocolate and it's really good, and you want to eat another piece, that is because dopamine is going up in the nucleus accumbens. And when you're teaching a student, when you're engaging into something, we were talking about that over dinner yesterday, when you're coaching as a kid in a sport, you want them to enjoy what they're doing, because that's going to activate the nucleus accumbens, and that's going to make them want to do it again, all right? And then the other part is the amygdala. The amygdala is where you have the negative reactions or the intense emotions to different things, but mostly negative emotions. So that is when you're pressuring a kid to work faster, to do things faster, and they're getting upset, and they you can see them fuming. that's going to interfere with their called executive function part of the brain, and that's going to make them perform worse. All right. So how do we measure that? Well, this is the test itself. So we present them a target, which is this character here on the left, and that's the go. This is the same that Jackie presented, but for little kids. We have with cartoons, and that's one important thing that I like, because little kids are not going to be interested in cards. So the target is go, and then if they press, they have to press any key when they see that, and they have to not press any key when they see the other no go, and then they have distractors. So you measure attention if they do if they pressure when they have to. You mention timing if they pressure it fast enough, because they have to do it fast. And then if they don't pressure when there's no stimuli, you measure attention. But if they pressure when there's no stimuli, they pressure all the time, that gives you the hyperactivity part. And then if they keep pressuring no matter what happens, if they just hit to everybody, it doesn't matter. The thieves, the bystanders, everybody gets hit. That's a commission error, and that measures impulsivity. So with that, we come with these graphs, and that this is important that you see the performance over time. And in this case, I put these labels. You want to have the lines as much high as possible. So better is higher, and worse is lower. And you can see on the top how you see the performance before treatment. This is with medication treatment, and in the bottom with after treatment. All right, and you can see how there's improvement. And for example, the green line is timing. So they're still having some timing issues, some issues about being on time and doing it fast enough, because they're doing it kind of slow. But you can see that most of the other elements were taken care of, were much better. And you can see that there on the left on the summary, okay? The other thing that you can do is you can, because in this case, for example, attention, which is the blue line, it's more or less all right through halfway through the test, and then it deteriorates at the end. So this kid is a kid that is going to need more frequent checkups with the teacher, because if you let him, like Jackie was saying, if you give him a 20-minute video, halfway through they're going to disconnect completely. So this is the kid that is going to need like every 5-minute checkups. Are you doing okay? Sometimes thumbs up, sometimes like that, or sending him messages if you're doing online. And that is what this particular kid is going to need, because not every kid is going to need the same thing at the same time. All right. In this case, for example, this is a before and after, and you can see that there's some improvement. Certainly, like the green line, that is the timing, went up. Is not so down. But in this case, what you see on the impulsivity, which is the red line, is that it's not doing well, but at the end, he's able to catch up. So this is a kid that, as far as an adaptation, is going to require longer time. All right. If you rush him, you're going to see the first half of the performance, and if you leave him a little bit more time, then you're going to obtain better results. All right. So that's how you adapt the accommodations for each particular kid. All right. So to conclude, impulsivity and attention, emotion and reward processing are key components in ADHD. It's not just hyperactivity, impulsivity, and inattention, also emotional regulation and reward processing. And they can be measured with some tools that we already have, and we are measuring them in the clinic. But it can be measured also in the general population, all right, to help you to titrate what your intervention for any particular kid. And as far as what I would say neuroscience-informed academic interventions, you want to reduce the distraction as much as possible, because that is going to improve the signal-to-noise ratio, all right? And this is something that I didn't talk about, but I just wanted to show you this picture. Signal-to-noise ratio is high in the left and low in the right. So that means that you're not going to see the image as compared with the background. So basically, you're trying to work in the middle of a very, very noisy room, and you can hear what you're trying to hear. So you need to increase the signal to noise ratio so that your signal is clearer and your noise is lower. All right, and that is what dopamine does. Dopamine reduces the noise, and norepinephrine, another of the neurotransmitters, increases the signal. So they do different things, and norepinephrine is more in the back of the brain, and dopamine is more in the front of the brain. So you see, even within these two networks, there's a little bit of complexity. And then the other part that you want to do is you want to engage the hot executive function. So you want to increase the reward. You want to make it very interesting, and also make it relevant to them. You want to touch their emotions. And that's why if you tell a story, sometimes it's much more easier to remember than if you just tell them facts. And that's why you engage the emotional component and you engage the reward, all right? So try to go away a little bit from, or a lot from memory, and involve excitement, and that's going to engage the amygdala. And then the last part is that some kids are going to have, remember that I told you about the default mode network when you're daydreaming? Some kids have problems shifting from daydreaming to task-oriented networks, and that's why they need a little bit more time. And they're going to need a little bit more reminders and a little bit more signals so that they can shift from the mind wandering to the task-oriented network. Okay, I think this is all I have, and thank you very much for your attention.